Hi, my name is Elena, and today we're going to talk about prone positioning and ARDS protocol and how just our oxygen exchange and blood flow affects all our systems and how prone positioning helps a lot of our ARDS patients to be able to oxygenate better and have a better outcome. Okay, so in our next slide, our objectives are going to be introducing the assignment, description of our pulmonary circulation, definition of prone positioning in ARDS, our distribution of pulmonary blood flow, Poselli's law, our zones 1, 2, and 3 of our lungs, effects of cardiac output, ventricular preload and afterload, and myocardial contractility. Discussion of ARDS management, and then that's going to continue a little bit because it is a little bit more information on that. ARDS net protocol, prone positioning in ARDS, and then we're going to summarize the whole presentation and show my works cited. So pulmonary circulation. Pulmonary circulation is a short, low pressure loop of blood circulatory system that carries deoxygenated blood from the right side of the heart into our lungs, which are here shown in this picture. Then they will pick up oxygen and release carbon dioxide, and then return towards our left side of the heart with rich oxygenated blood, and that'll be pumped back into the rest of our body. So I will kind of show you a description of how that works. So from our top of our body, the deoxygenated blood will come in and down from the superior vena cava into our right atrium. And then from our lower part of our body, it'll come up from our inferior vena cava into the right atrium. So it'll go into the right atrium, and then it'll cross this little valve called the tricuspid valve and go into the right ventricle. Once it's in the right ventricle, it'll go up this little valve right here, and that is our pulmonary valve that will then go up and go into the left lung and then into the right lung. Once they do that, a gas exchange where carbon dioxide is released and oxygen is picked up, then it will come down from our pulmonary veins and it will come into our left atrium. So this one, from this lung, it'll come from this side, and then from this other lung, it'll come back and go into there. So they will be both dumped into the left atrium. Once in the left atrium, it'll go past another little valve called the mitral valve that will then go into the left ventricle. From the left ventricle, it will push through the aortic valve. Once it's in the aortic valve, it'll go through the aorta and it'll go through the superior aorta that'll go up to the top portion of our body, and then the inferior aorta that will go down to the bottom of our body. In this other picture right here, there's another little kind of description of how kind of gas exchange is. There's, like a membrane and it's permeable. So like gas and oxygen are released and traded out through the little membrane. So like CO2 will go in and then the O2 will come in from the other side, and then they will like plump up because it's oxygen rich, and they'll just kind of keep moving through our blood flow. Prone positioning. So prone positioning is a medical technique where a patient, often with like severe respiratory distress or ARDS, is turned on from their back. Like when you normally lay down in a hospital bed, you are on your back with your belly up. For this positioning and this technique to help these kind of patients be able to oxygenate and ventilate a little bit better, they flip them over on their belly. So basically they are laying on their belly with their back up, just to improve that lung function and be able to oxygenate a little bit better. ARDS stands for acute respiratory distress syndrome, which is a life-threatening severe lung condition categorized by widespread inflammation, fluid leakage into the air sacs, which are called alveoli. They look like little grapes, and stiff lungs, causing low blood oxygen levels. Often arises rapidly within hours and days from pneumonia, sepsis, or trauma, requiring intensive care, ventilatory support to improve oxygenation. So basically our patients kind of hit a wall where they are no longer able to ventilate and oxygenate for themselves. So then we have to help with that.